My name is Katrina Fleming and I'm an experienced resuscitation practitioner, and my clinical role involves attending cardiopulmonary arrests as part of the resuscitation team, and I've been doing this role in excess of 20 years. There are reasons for making do not attempt cardiopulmonary resuscitation decisions, and one of the most important is when a patient wishes to refuse the treatment. They do not want cardiopulmonary resuscitation carried out to them as they are dying. As healthcare professionals, we can support them in this wish by directing them to resources to make advanced decisions to refuse treatment. This is a legally binding document, and if it's made correctly, will ensure that the patient's wishes and refusal for this treatment are adhered to at the end of their life. The second decision relates to where clinicians believe that cardiopulmonary resuscitation as a medical treatment is unlikely to be successful for this patient. There are times when patients have irreversible, inoperable, incurable cancers, or they have irreversible disease processes that would make CPR unlikely to be successful. This is a clinician-led decision, and no patient and their family can insist that we carry out a medical treatment that will not be successful. It's vital that you are clear that because this is a medical treatment that you believe will not work for this person, that you ensure that they understand that you are informing them that you have made the decision as part of advanced care planning. When a person is dying due to irreversible medical conditions, it's important to allow them to die naturally. The last thing we want to do in that situation as they're dying is to commence chest compressions, to give an electric shock, to place tubes into their airway, and to use a bellows to actually physically make them breathe, knowing that none of this will work, and rob that person of a natural death.
Stand clear.
Stand clear. Remove the oxygen. Stand clear. Stand clear. Shocking.
Shock.
Now.
Perform CPR.
Lucas, turn on. Begin CPR. There are times when the patient or their family will disagree with our rationale that CPR is unlikely to be successful. In these situations, it's important to listen and to hear the patient and their family's concerns, to be compassionate and kind, and understand that this is a really difficult time for them. It's important that we explain our rationale and try and help them to understand that the treatment would be ineffective. And because the treatment is ineffective, it would be brutal and harmful. Involving all members of the patient's multidisciplinary team in cardiopulmonary resuscitation decision-making may avoid the need to offer a further second medical opinion. But where the patient or those close to them disagree with the DNA CPR decision, a second opinion should be offered. If the patient is not at imminent risk of a cardiopulmonary arrest at a particular point in time, then they can remain for cardiopulmonary resuscitation while seeking a second opinion. This allows them time with a different clinician to sit down and to understand the patient's condition and the reasons that we think that they will not benefit and respond to cardiopulmonary resuscitation. If the patient is at imminent risk of a cardiopulmonary arrest and the patient or their family still insist that this patient is for cardiopulmonary resuscitation, you need to place the DNA CPR decision, and you can continue to seek a second experienced clinical decision, but the important point is that the decision must be in place to ensure and protect the patient's safety. There are times when clinicians are not sure whether cardiopulmonary resuscitation would be successful.
Clinicians have a duty to protect life, but this must be balanced with the obligation not to subject the patient to treatment that they would regard as inhumane or degrading. And in these situations, shared exploration and decision making will be critical to balancing the risks and burdens that will occur as a result of surviving a cardiopulmonary arrest.
It is likely that the patient's condition will be worse following a cardiopulmonary resuscitation attempt. And what we need to try to do is have a shared decision-making process. We need to find out if this deterioration in their medical condition would be tolerable to their quality of life. Once we understand what they will accept as tolerable, we can then decide if they wish to undergo cardiopulmonary resuscitation or to have a do not attempt cardiopulmonary resuscitation decision that is put in place.